Welcome to the IFSO podcast. This podcast is sponsored by WakeWorks Clinics, the Netherlands.
Okay, hello everybody. This is the first IFSO European chapter podcast about pregnancy following bariatric surgery. My name is Dr. Sjaak Pouwels. I'm originally from the Netherlands, but I'm now a surgeon in training in the University Clinic, the Marine Hospital in Herne in Germany. And I'm here with Dr. Amihai Rottenstreich. He is an obstetrician and physician scientist at the Rockefeller University and Maternal Fetal Medicine Service at Northwell Health in New York in the USA. The ideal subject to talk about pregnancy after bariatric surgery. Amihai, welcome.
Thank you. It feels great to be here.
How are you doing?
Good, thanks.
We're going to talk about your favorite subject. We prepared a few questions, and I'll start with the $1 million question. The $1 million question is when. In your professional opinion, when should patients that had bariatric surgery get pregnant?
So I will answer with the $1 million answer, which is it depends. It depends on several factors that includes patient's factors as well as the surgery itself. There are different guidelines to suggest the optimal time in which patients should conceive after surgery, with most of them limiting the time to conception for at least 1 year, up until 18 months or up until 24 months after surgery. The problem with these arbitrary time limits is that it does not rely on any level 1 evidence data. We have different conflicting results showing that conceiving in the earliest time after surgery may or may not increase the risk of delivering a small for gestational age infant, and I will call it as SGA, small for gestational age infant, which is the main risk which we fear from in conceiving in the early catabolic phase after surgery. The problem is that we have to remember that a lot of our patients, our female subjects, may be towards the end of their reproductive age, and sometimes this delay in conception up until 2 years may hamper their ability to conceive. Therefore, whether or not we should allow our patients in a shared decision-making to conceive after surgery depends whether or not the most important factor is whether her weight is stabilized. Meaning, for some patients, it could be as early as 6 months after surgery. And the other guidelines that also support this is the Royal College of Obstetricians and Gynecologists, the ARCO guidelines, which suggests that instead of using these arbitrary time limits, this should be an individualized decision. And if a patient wants to conceive, and if you follow her and you see that the weight loss is stabilized, this may be a good time to consider pregnancy if we know that she's stabilized in terms of her nutrition. And then, again, in a shared decision-making, we can decide whether or not to counsel her that she can start her attempts at conception.
Okay, so we do agree on the arbitrary timelines because from a surgical point of view, some people say 6 months, some people say 1 year, some people say 18 months, and some people say, for example, not get pregnant at all. That needs to be more evidence based. In my surgical point of view, I've seen 2 categories of patients. In terms of patients that are already pregnant after bariatric surgery and then come for counseling, or patients that have a wish to get pregnant, so they come for counseling beforehand. And how do you, as an obstetrician, want to counsel these patients?
So, first of all, I think that's a great point, because what I want to highlight is that our counseling does not start after the surgery. We should start having this reproductive health counseling in the perioperative phase, and I believe it should be part of the preoperative checklist, meaning every woman in a reproductive age who wants to undergo weight loss procedure should have a gynecologist, maternal fetal medicine consultation prior to the surgery. And the main reason that I suggest this should be a part of the preoperative checklist, is that while most surgeons saying to the woman, okay, you need to delay conception after surgery for 6 months, 12 months, 24 months, most of them does not recommend in their same, while saying, please delay conception, they're not recommending any mode of contraception. And the problem is with saying to a woman, okay, do not get pregnant, but then not providing any adequate mode of contraception is highly problematic. And we also know that prior to surgery, it is recommended that women using estrogen-containing contraception should avoid using it for 1 month prior to surgery. And I know that we have encountered also, in my personal experience, several women who were pregnant at the time of the surgery itself. And also right after the surgery, if there is not adequate provision of contraception, some women, because of the improvement in her fertility, may unintendedly conceive after surgery. And that's why the most optimal thing is not only saying to women, okay, you need to delay conception, but also giving her a good consultation regarding what is her adequate contraceptive method to use after surgery, while also avoiding the 1 month prior to surgery. Also, in the early postoperative phase, we should also avoid using estrogen-containing contraception because of the increased thromboembolic risk, which, according to some studies, may extend up to 6 months after surgery. And also, right after the surgery, we cannot use, and that goes also to the long term, of course, both estrogen-containing oral contraception and also progesterone-only pills, which are also given orally. And this is because also after sleeve gastrectomy, and we have showed that in other studies that we have performed, and of course after malabsorptive procedure, that there is an increased risk of malabsorption of the oral contraception that the woman uses, which may increase the risk of conceiving unintentionally. And before I answer whether or not how I counsel differently the women who comes when she is already pregnant and those who are not pregnant, and I give them the consultation before, we have to provide adequate contraception. And because we cannot use any orally administered contraception, we can use either IUD, an intrauterine device, both progesterone-containing and non-hormonal IUD. And in women who are under 90 kilograms, we can also use the hormonal patch, what we call EVRA, but again, not in the early postoperative phase because it's containing estrogen. And another option is not in the early postoperative phase, the vaginal ring, which also contains estrogen. And the last option is an hormonal implant, which gives long-term contraception, which contains only progesterone, levonorgestrel. And this is something we can use right in the early postoperative phase as well. And now we get to the question how we counsel differently those who are pregnant and those who come to us before getting pregnant and wants our advice. So we have to make sure in those who are not pregnant, again, if the weight has stabilized and whether or not her nutritional status is well optimized. We have shown, for example, that the most important and the only independent risk factors for having anemia during pregnancy is the presence of anemia prior to getting pregnant. And that's why an anemia is well associated with adverse pregnancy outcomes. And that's why this is just one example of something regarding to the nutritional risk that we have to make sure it's optimized prior to pregnancy. If a woman is already pregnant, it depends at the time that she is coming for a first consultation. We would obviously want to see her as early as possible during pregnancy, because sometimes late during pregnancy, you cannot do a lot to change the determination of how the pregnancy will continue, because we know now as obstetricians that the most important factor in determining the outcomes of the pregnancy is what's happening in the early pregnancy, in the first trimester. And this includes also, again, nutritional support during pregnancy, adequate follow-up in terms of the nutritional support, and also from the obstetrician side, also adequate fetal growth evaluation during pregnancy, again, because of the increased risk for small for gestational age infant.
That's a very long answer on a very difficult question. Yeah. So I'll summarize. So in your obstetric professional opinion, most important is adequate counseling, ideally pre-operatively, in terms of adequate birth control, tailored to a patient needs, patient's background, and in your opinion, when you need to counsel patients that had bariatric surgery, anemia is one of the important factors, and vitamin status is important. Secondly, actually thirdly, weight loss needs to be stabilized. They need to some sort get a stabilized weight after surgery. I would like to ask you a follow-up question to these important points, because nowadays, bariatric surgery and metabolic surgery in general is a multidisciplinary approach, and there are a lot of people involved. And I've worked in the Netherlands, I've worked in Germany, I've seen a few things in the US and the UK. The gynecologist or the fetal medicine specialist or the obstetrician is never there.
Mm-hmm.
How can we increase counseling beforehand, so before bariatric surgery, in women in a childbearing age? And secondly, how can we attract fetal medicine specialists, obstetricians, gynecologists to be a part of the treatment of obesity and related problems, related consequences?
That's another great question. And I think, like any other chronic medical maternal conditions, the best way to handle these issues is having a multidisciplinary clinic. And again, as I said before, if you will have a gynecologist consultation prior to surgery as part of the preoperative checklist in women at their reproductive age, it will make sure that gynecologist has the knowledge, because suddenly they will have a lot of population of women that come and need to get this consultation. Because now what happens around the world is that they do not get, in most cases, any consultation regarding contraception, regarding the time to delay conception, and they mostly see the surgeon. They do not see their gynecologist or obstetrician in regard to the weight loss procedure that they are undergoing up until they get pregnant, as you said, many times. So that's why the best way to handle it is having a multidisciplinary clinic. I can say that at the time that I work in Israel, before moving to the US, we have established the first clinic in Israel dealing with these issues, a multidisciplinary clinic that included a nutrition specialist, maternal fetal medicine specialist, a surgeon, of course, psychologist. And again, that's the best way, in my opinion, to handle these issues and giving the best consultation for this subpopulation of patients.
And you did that in Israel. You're now in the US.
Yeah.
Did you experience, or did you create a similar multidisciplinary approach in the US, or do you see?
I tried. There was some.
There
were some domestic challenges, let's say, but we're working on it.
One other specific topic is vitamin and mineral supplementation before and after bariatric surgery. A lot of international well-known researchers and colleagues are still writing tons of papers on a monthly basis, and we still do not have all the answers. What do you think is the most ideal approach to assess vitamin and mineral status in pregnant patients after bariatric surgery? And do you have any tips, tricks from your own clinical experience? How do we need to supplement potential deficiencies, or do we need to adjust vitamin mineral intake? Please guide us through.
I totally agree with you. That's a huge issue that we encounter when seeing these women. I, for myself, made a Word file that I included all the different systematic reviews and the different guidelines from different authors regarding the optimal supplementation regimen. And that completely varies between different authors. I think one of the most factor is that one size does not fit all. I know that there are some groups that try to create a specific formulation. I know that some group in Belgium created such formulation. But again, that could be a good beginning point. But when you want to treat the individual patients, you have to get, again, adequate consultation from the nutrition specialist prior to pregnancy and during the follow-up during gestation. Because again, and this is one of the things that the bariatric procedure itself have a detrimental, an important factor during the course. For example, the nutritional risk that we see following gastric bypass, and also specifically for one anastomosis gastric bypass, and we have shown that the risk for anemia, for example, is much higher compared to sleeve gastrectomy. In our cohort, which was the first, by the way, publication regarding one anastomosis gastric bypass, we saw that 1/3 of women required intravenous iron transfusion. And we do not see that so commonly after sleeve gastrectomy, for example. And that's why there is no specific answer for all the women, but we have to make sure we have the adequate follow-up during pregnancy by the nutrition specialist.
It's still an intriguing topic because we talk about it. We can talk about this one specific small topic, but we'll can probably talk for hours and hours.
Yeah.
And this podcast will be a lot longer than 30 minutes. You already touched the subject of different bariatric surgical procedures. Nowadays, if we look at scientific works of Professor Angrisani, for example, from Italy, OAGB, the one anastomosis gastric bypass, is being performed very often. Sleeve gastrectomy, Roux-en-Y gastric bypass, but also the more unknown procedures or not recognized procedures. One of them is the ileum transposition, ileal interposition. There is literature, but they're not globally distributed. Do you have any tips, tricks? How should we counsel patients or monitor patients that get pregnant based on the bariatric surgical procedure they had?
Again, a very good point and a very good question. I want to highlight several aspects, 3 aspects. The first is the nutritional risk, which we highlighted before, that is completely different between malabsorptive compared to restrictive procedures. So that's one aspect. The second aspect is let's say, the obstetric risk. And again, specifically the risk for small for gestational age infants. And we have shown that the lowest risk for having small for gestational age infant is with the first procedure that was, again, we're not routinely performing it anymore. It's gastric banding. That's have a lower effect on weight loss, which is less durable, and we're not encountering almost these kind of patients anymore. But the second procedure among the popular surgeries that are being performed today is sleeve gastrectomy, and the risk of having a small for gestational age infant after sleeve gastrectomy is between 15 to 20%. Again, the general risk of small for gestational age in the population is defined as 10%, and that's why it's higher than the overall rate. But again, not very high. Whereas following malabsorptive procedure, the risk is significantly higher. And this has been shown already in systematic reviews. And we have most data regarding Roux-en-Y gastric bypass, which the risk is around 30%, meaning 1/3 of women after Roux-en-Y gastric bypass will deliver small for gestational age infants. And we have shown that after OAGB, and again, this is not a very large sample size, but around 40 women that we had, 40% of them delivered a small for gestational age infant. So definitely in terms of obstetrics for delivering an SGA infants, the risk is higher following malabsorptive procedure. And the last aspect, the third one that I would like to highlight, is the surgical risk. And this is something that is not getting enough attention, particularly in the decision prior to the procedure on which procedure should we counsel the patient to undergo. Because again, this is again why I think multidisciplinary clinic will have a role, because one of the factors that I believe should be taken into account on the decision which weight loss procedure the women should undergo is her will to become pregnant after surgery. Because what we saw, and the literature stands for that as well, that the risk for surgical complications is not negligible, meaning according to different studies, up to 1% after malabsorptive procedure we need some kind of surgical intervention during pregnancy. Whether after sleeve gastrectomy, and we have published our results for over 200 women, which is the largest sample size that I know in the literature up till now, we did not encounter any surgical complication after sleeve gastrectomy during pregnancy. And I want to explain to our listeners that having a surgical complication during pregnancy may be hazardous not only for the mother, but also for the fetus and increasing the risk of pregnancy loss. And that's why I think during the preoperative phase, it is important to highlight to the women this factor that other procedure other than sleeve gastrectomy, by the way, also gastric banding, that we have shown many complications of gastric banding. The need to adjust the band during pregnancy was very common in these pregnancies. And that's why I believe, again, along with the other factors that we should take into account, that sleeve gastrectomy has its advantages for this women, for this subpopulation of women who want to conceive after surgery. And it's important to highlight that for those who fear that the weight loss results may be less optimal after sleeve gastrectomy compared to other procedure, that, okay, we may take this risk into account and we may need additional procedure in the future, but during pregnancy, we definitely decrease the risk of having a surgical complication during pregnancy if we choose sleeve gastrectomy. And that's a point I think that is very important to highlight.
Yeah, so in terms of pregnancy complications and the procedure of choice, you're a personal and professional fan of the sleeve gastrectomy in patients that want to get pregnant, if I understand you correctly.
Yeah. Yes.
Okay, that's a good point for our listeners. I would like to ask you a question of a different kind of question in terms of science. You're on the forefront of obesity and obstetric and gynecological science. If you look at PubMed in the last few years, you'll see an increase in literature on new techniques, on literature on weight regain, on strategies on reflux. But if you look more precisely in terms of obesity in gynecology, obesity in obstetrics, the amount of literature published is significantly less. As a forefront of science, the both of us, what should we do to get more adequate, more high-level evidence out there? And one thing, and that's from my own personal experience, those arbitrary time limits. When should I get pregnant? How can we, in collaboration, of course, gynecology, fetal medicine, and bariatric surgery, how can we design studies to get high-level evidence out there? How can we improve the scientific collaboration between, on one side, bariatric surgery and the gynecology, fetal medicine, obstetrics on the other side? What's your opinion on?
So I will give an example from another field in the field of gynecology that is, for example, was heavy menstrual bleeding. And that was something that women were feared to discuss from shame, from other reasons. And only after there were, massive campaign that increased the awareness for heavy menstrual bleeding and how to adequately address this issue, only then it gained popularity and increased the number of publications and studies that are being performed. Also regarding this, obesity among women. This is something that a lot of women fear to discuss with their friends, with their family, with their doctors. Many women with obesity refrain from getting a medical consultation because of some kind of stigma that they have. And also after bariatric procedures, many patients that I encounter trying to hide the fact that they underwent bariatric procedure, and sometimes they do not getting any nutritional specialist advice, obstetrician advice, surgical consultation during pregnancy, and they just come to the delivery room and, okay, one of the factors that you see, the anamnesis, is that they underwent bariatric procedure. And we see it very common. And I think we have to raise the awareness in the public for this important issue, particularly now with all the well-known new obesity medication that we have to improve weight loss, along with the effect, of course, of bariatric procedure. This is something that we have to discuss. The specific population of women with obesity after bariatric procedure, the fear of weight regain, and only if we will raise the awareness and improve the collaboration between different specialties, we can start having good studies, prospective, randomized control trials that address these issues. For example, one point that I always thought about that among women, even after bariatric procedure, and women with obesity before bariatric procedure, whether or not during the time that they attempt to conceive, will these new obesity medications, we can use them as a bridge in order to improve weight loss, even after bariatric procedure, in order to improve pregnancy outcomes, because right now we cannot use this medication during pregnancy. And this is just one example of many other studies that are important to perform. And we have we have large sample size to perform these studies. We just need to raise the awareness for it.
Yeah, good. Very, very, very good point. In your own practice, how did you do that? How did you collaborate with bariatric surgeons, for example, in Israel, where you're from, or now in the US? How do you get bariatric surgeons or surgeons in general engaged in a gynecological or obstetric problem?
So I believe first that collaboration starts when the surgeons see that you really deeply involved in the field. Before starting addressing these issues, learned a lot about bariatric procedures, because you cannot counsel these patients if you not have at least basic knowledge regarding the different bariatric procedure and the differences between each of them. And if, again, your colleagues see your deep interest in it and how much you want to improve patient outcomes, collaboration will be fruitful. And in terms of how performing studies, again, like any other fields in medicine, drug companies have a significant role. And because these issues of diabetes and obesities are well common, it is not that hard to convince pharmaceutical companies to perform studies. We just need to have good starting point, good collaboration between different, again, specialties, and then we will be on the good road into improve our patient outcomes.
That sounds very good. I would like to close off this first podcast. Thank you very much for your valuable insights. Thank you for coming on the podcast, and of course, thanks to our listeners. And hopefully, you'll listen to us on our next podcast. Thank you very much.
Thank you.
This podcast was sponsored by WeightWorks Clinics, the Netherlands. Thank you all for listening.